Hello, my name is Johan van Soest, and today I'm going to talk about medical imaging data for secondary use and how we've implemented that within Maastricht University, Master Clinic, and in the Netherlands in general. So, for a short overview of what I'm going to talk about in this 20 minutes is first of all about the local image handling, how we're dealing that with that within the hospital, specifically within Maastro Clinic, radiotherapy clinic. Afterwards, I'm going to talk about the central image handling, and as the last component, I'm going to talk about the semantic DICOM part. So how we're using semantic web technologies together with imaging data. So let's start first of all with local image handling. And first I want to say that this local image handling is specific for Maastro Clinic, which is a radiotherapy clinic affiliated to Maastricht University Medical Hospital and affiliated to the Maastricht University in general. However, it's a separate radiotherapy clinic. So how the current infrastructure on a technical level works over there is that on the clinical side, we have a clinical workstation. We have the clinical PACS system or the vendor neutral archive, the VNA. And of course, this, modalities. Think about a CT scanner, a PET CT scanner, but also let's say the treatment modalities itself, because they're all using DICOM, so the medical imaging protocol, to guide and steer those machines to deliver the actual radiotherapy. However, this is all on the clinical side of that data. It's not on the researcher side. So how do we get the data from the clinical systems for secondary use for research purposes to those researchers here indicated on the right? So first of all, what we're using is a component called the Clinical Trial Processor, or shorthand CTP, which is developed by the RSNA, which is the Radiology Society for Northern America. And what they have developed there is basically a tool which works rule-based and can de-identify the metadata part of the medical images. So the part containing information like the patient identifiers, the doctor identifiers, information about the modality settings, so what voltage was used for a CT scanner, for example, or for the radiotherapy dose actually. All that information can be de-identified using a rule-based system, which looks as a XML standard, where for every metadata element, you can decide what you want to do with that data element. So for example, over here, if we see the series date, so the date when that specific, for example, CT scan was made, that we replace that with a dummy date, for example, or other dates or other values, we can remove them, add days to it or hours to some date or time, hash values, for example, over here, hash UID, or do any kind of modifications, which will result that the image is properly de-identified. However, that the images are still usable, and also that the referential integrity among images is still there and is still working. For patient identifiers, for example, we can also use there a lookup database with keys to identify the clinical patient identifiers and lookup replacements, so that, for example, patient 12345 can be with ID 12345 can be changed into patient XYZ, for example. The output of this clinical trial processor then goes into a research pack, so research picture and archiving system and communication system, where then researchers can use workstation software like they have in the clinic over here on the top left, that they can use it also in research as well, indicated here on the bottom right. So researchers can then interact with the research workstation and use the data or the medical images there. However, what we see more and more is that researchers just want access to the imaging files and use them directly. What we are currently doing is then store them on a network drive or network share where the researchers which have access to the specific folder can then find these images and work with them. I'll come back on it later what kind of challenges that will bring. So this is the current technical infrastructure where you see there is a clear boundary between on the left what's happening on the clinical side and on the right what's happening on the research side, where the only link in between is this clinical trial processor processing and de-identifying these images, and therefore also making sure that what's happening on the right side in research doesn't impact directly on the clinical side. So it doesn't, for example, if a researcher would have a high computational load, that wouldn't affect the clinical systems over here. Furthermore, what's happening in this CTP is that we de-identify images per project base, meaning that all the de-identification process with the rules mentioned before are customized for every research project. I will come back later in this presentation why as well. So this is a technical infrastructure, but how does it look then from an organizational point of view and or an administrative point of view? And how that works before actually the researcher gets access to the data, it starts basically on the left where the researcher files a data request in our internal ticket system. In this internal data request, he or she has to specify what kind of data he wants to use, for what purpose, and why he needs that. Then afterwards, this will go to the local institutional review board, so the medical ethical committee locally, to see if this is allowed to use from an ethical standpoint. If it's retrospective data and doesn't intrude into the clinical process, let's say, this is mostly acceptable in most cases. And afterwards, there's also a check with the security officer. Therefore, it's very important that the researchers in the data request specify what the purpose is, as he will check, of course, whether it's in line with the whole GDPR regulation regarding patient privacy. Afterwards, if both IRB and afterwards the security officer approve, then this ticket is handed off to the IT department to extract the data and let the data flow through the infrastructure as mentioned in the previous slide. And after this data extraction happened, the data, that folder or that partition on the clinical pack system will be made available to the researcher, or the researcher will get authorizations to access that, and he or she can work with the actual data for that specific research project. This is all fine. However, what we see in recent times is that this network share is usable, but it's not the most optimal way. And what we also see is that most of the researchers use this network share, but actually don't use the research pack system or the research workstation, mainly because the research tools aren't oriented towards the clinical systems like a pack system or an actual clinical workstation, but are more explorative of nature to use. So what we want to do in upcoming future is replace this network drive, what we had over here, with an XNAT server, where XNAT is basically a software package where you can define, or web-based software package where people can define projects, upload their medical images and data into these projects, can share projects with other researchers, internally in this case, and where the researchers can use a REST API or web-based API to download these images and use them. However, also get access to some part of the metadata, specifically the patient study series image information, which is in the metadata of these medical images. So that's part one, what we're currently in the process of transitioning from, let's say, that network drive to more towards this XNAT server internally. So this is the current setup, what we have in a hospital. And maybe in the future, we can link that XNAT server directly to the research workstation. However, that fully depends on the research workstation capabilities as well. XNAT has options to talk the DICOM communication protocol. However, whether all features are included what the research workstation will need, that's unclear for us. So we're currently holding off to make this change, and we'll stay on the previous pattern where we still have that pack system. Although we would prefer to maybe remove that, as we then don't have 2 times the data duplicated on the researcher side. So following up on the local infrastructure, we can go to the central image handling. And the central image handling in the Netherlands is currently maintained by a initiative called HealthArray, which is an initiative to provide services for researchers by researchers. So there are all kinds of components and services available within HealthArray, among other software, but also education and training, ethical and legal support to find out what's allowed and what we can do, especially in the genomic side of data and so on. But also IT and digital workspaces, research facilities on, let's say, the technical side and so on. And the portfolio of tools being supported and made available for researchers varies per domain. But for now, I'm going to talk mostly about the imaging part. How does this work then on the central side? Well, on the central side, HealthArray has set up, and that's already for, let's say, probably 8 years, something like that, a central XNAT server where research groups and research projects and the PIs of these research projects can request a project on the XNAT server. Then afterwards, these research projects, if that access is being granted, research projects can link up local hospitals or multiple local hospitals to export the data for that research project to the central server. So for example, if we would have local hospital A and we would have clinical systems, for example, PAC system or workstation, they can send that locally to their clinical trial processor, as what I explained before, what we're using internally in a hospital. This trial processor is then configured to upload data for a specific research project, which is made available on the central XNAT server. There is then communication between this local CTP instance and the central CTP instance receiving the data, which goes over a secure connection. And then this CTP server receives the data and passes it on to that local XNAT instance, or that local XNAT, or the central XNAT server, sorry, central. This is then being implemented for all hospitals participating in a specific research project, in a multi-center research project, where the researcher will get access to the central XNAT server where he or she can pull the data from, or maybe put a compute node next to this XNAT server at their own expense to perform calculations on these central images. So how does it work, this central part from an organizational perspective? First of all, what HealthArray provides is a freemium model, meaning that the first X amount of gigabytes, which is listed on the web page, is for free for every project, and afterwards you have to pay per gigabytes of storage per year as a research project. Furthermore, what's not allowed to use is that this system is not available for prospective clinical trials. The main reason to exclude this is for these prospective clinical trials, where, for example, hospital A, B, and C need to upload images, and some expert will review these images centrally before a treatment decision is being made. We don't, or a health authority doesn't want to be involved in there, mainly because there's a lot of liabilities in there, and also uptime guarantees, which at the moment we cannot do and we cannot facilitate basically, because it would mean that we need a 24/7 service desk, for example. Um, the second part brings then to the service desk. What is available is a service desk to request to make a project or to set up a project. And then also the service desk will give support for setting up this project, especially the local CTP, so de-identification pipelines, which need to be installed local within every hospital, because we see that most of the times there things can go wrong. For example, hospitals think that they properly de-identified the images, but if we then look at the private DICOM tags, for example, then there's still physician names, patient names, or other identifiers still in these data elements. So therefore, we give support for during the setup of a research project and give support for every submitting site for a specific research project. If a hospital comes back for a second research project, we will probably reuse the CTP script made for the first project, but we will go through the whole testing procedure again, or QA procedure again, to make sure that nothing has changed, also in terms of scanning parameters and scanning settings, which mean that different DICOM images can be generated. So therefore, this is a really custom process done for every project, every time over and over again. Second, the service desk also handles the maintenance of that central infrastructure, of that central XNAT instance and that central component of CTP. And also give support for research projects if they have issues for downloading images, for making sure that everything works, and so on. One part of it is that before a research project really starts to upload all the images, we will ask, for example, the study to download one of the patient's or the sample images again and run it through their intended analysis environment, that we definitely know that for hospital A, B, or C, that pipeline of getting the data locally, de-identifying it locally, sending it to the central location, storing it centrally, downloading it from the central location, and then using it in practice, that this whole pipeline actually works. Furthermore, to dive a little bit more in depth regarding that CTP part and the de-identification, is that this pipeline, what we're using to de-identify the images, is based on DICOM supplement 142, which is basically the HIPAA compliant version of what DICOM metadata elements should be stored or shouldn't be stored. Per project, we're deviating from that HIPAA compliant supplement, mainly because, for example, if we have a PET-CT scan, we need the weight of a patient, which is in the DICOM metadata. Otherwise, we can't calculate several information elements based on the PET data, which is a common element, for example. So it's really starting from that supplement 142 and then make deviations where there's really a need for the hospital to have this information included, and therefore there's also a link to that you really need this information. Furthermore, the custom de-identification per hospital, per individual project, as just mentioned before, this is done for every project and for every hospital, that to make sure that this works and is correct for that specific project. And finally, also, as mentioned before, that we test the whole pipeline from front to end with the researcher before giving the green light to really start going in that research project. So that's on local and central image handling, but that's purely on images. However, we have more information, of course, coming from EMR systems and so on. So this is a slightly different topic, and I want to go briefly through it. Um, if we look at the DICOM standard, we know that we have image data and we have metadata. And we know that the DICOM standard is described standard and is around from the 80s actually. And we know that modalities, so a CT and a PET scan or CT and an RT struct are linked based on unique identifiers, UIDs. And we know that there's a hierarchy in every file. So every file contains information on the patient, on the study, on the specific series, so the specific CT scan, and the specific image, so the specific slice of a CT scan, for example. This information can be stored in a PAC system, which is basically a DICOM interface to a file storage usually, and a database to store that some parts of the metadata, which is in the DICOM objects itself. However, because the standard is already around here from the 80s, there's still some legacy in how to use it. If we, for example, look at the radiotherapy perspective, we have a CT scan, we have an RT struct, which is the contouring or segmentation of individual organs on a CT scan. Based on that, a radiotherapy treatment plan is being made, and based on that, a radiotherapy dose is made. If we would then ask a question like, give me all lung cancer radiotherapy DICOM sets where a photon plan was irradiated in clinical practice with a GTV larger, so the tumor volume larger than 100 cc, and the mean lung dose, so the dose to the lungs, is less than 20 gray. What we would need to do is ask all these different files and modalities, so the CT, RT struct, the RT plan, the RT dose, and the EMR, to answer that question. Specifically for the first line, we need to go to the CT and the electronic medical record. For the second one, we need to look in the RT plan and also look in the EMR, which was the irradiated RT plan. Then we need to go to the RT struct to find out what the volume is with more than 100 cc. And then we need to ask the mean lung dose less than 20 gray. So to ask all these questions, and when looking then into the DICOM standard, it means that we need to do a lot of back and forth querying between all these different systems to resolve such a question, which is not a question common in clinical research or clinical practice, but is a common question in clinical research. So what we did is we looked at semantic web and using semantic web and linked data, because the promise of semantic web is that we can link patient data coming from an EMR system. For example, that we have a patient called Johan van Soest who has a certain disease and has a clinical tumor classification in there with a T2 and N0 and M0, that we can link that to the actual imaging information. For example, that TNM can be based on a CT scan of that patient or maybe an MRI scan of that patient. But that CT scan is afterwards being used to make the RT struct and actually the radiotherapy treatment plan maybe. So semantic web and linked data gives you the opportunity to link the EMR data together with the metadata information from the DICOM data based on public web standards and using URLs and all these kind of things. And also you can add more links to it. For example, that the disease was treated using this radiotherapy plan. So using all this combination of tools, we can create a web of data where we can more easily or in one query find the result what we previously had to do in multiple queries. One example of what we've done in there, and this is actually the last slide on that one, is for example, as a proof of concept, one of our PhD students, Petros Kalendralis, he worked on several data sets where he had information from the electronic medical records, so the clinical data, which he converted into RDF. He also converted the DICOM metadata of the scans related to these patients into RDF, and he also had DICOM-derived information, for example, tumor volumes, but also more advanced features, what we're calling radiomics. He also converted that to RDF and put all of that in one triple store or a virtual triple store. And at the end of the day, what you could do is query this triple store to ask all these kinds of complex questions like what we mentioned before, and would get more answers out of that than, yeah, asking all these questions individually. So with that, I'm actually at the end of my presentation. Unfortunately, I couldn't be here today to present to you in person. However, if you have specific questions, feel free to ask them at my email address listed above. And I've included here also several useful links, maybe if you're interested more into the topics and things that I presented here today. So thank you for your attention, and yeah, please let me know if you have any further questions.